Welcome to Pulmonary Critical Care Fellowship at IU. I've made a series of videos to introduce you to the VA system, and this will be the first one. It is on the MICU. So one of the most important aspects of working in the VA healthcare system, if you have not had the opportunity to already, is that you literally get to take care of our nation's heroes. You'll notice as you bounce from hospital to hospital on our campus that for the most part the vets complain less. They don't take you for granted. They really need your help. They're grateful. They're often extremely happy just to talk to someone, and they'll literally talk your ear off if you let them. And they're appreciative and thankful. So it ends up being a very great place to work. There are tons of good phone numbers available on the survival guide. Since this is published to YouTube, I have not included those on this PowerPoint. Your duties in the ICU, you're one of two fellows. There's one pulmonary consult fellow as well. When the consult fellow is on vacation, the MICU fellow will cover both services. This can get pretty busy. It includes seeing consults, running the ICU, and doing HOMO2 and PFT evaluations. If the pulmonary consult fellow is going to be on vacation, the pulmonary consult fellow is responsible for notifying the PFT and HOMO2 techs that they will be gone and that you will be covering. It's very important that that happens. If you notice that you're not getting PFTs and HOMO2 evals while the pulmonary fellow is off on vacation, then you need to reach out yourself and tell them to switch it to you. Your duties as a MICU fellow, number one, is to run the MICU. One of the fellows should really be on campus and in-house, campus or in-house until around 5 p.m. You should supervise all procedures when in-house, and we recommend that the residents place IJs overnight if they're unsupervised. Many times, because of lack of training and experience in their first year, the second years in the VA ICU will oftentimes need your help supervising central lines. As far as admissions, you will get paged by the ER or by ward teams for ICU admissions. It's your responsibility to make sure they're evaluated and accepted to the ICU. The default is that we accept patients and we're here to help, meaning that we may feel like the patient does not need to be in the ICU or on our service, but the person that's sending the patient to us is worried about them. You can choose to admit a patient to the step-down unit or even leave them in a ward bed if you don't feel like they're ill enough to come to the ICU, but they should still be accepted to our service. At the worst, we can transfer them back to a ward service the next morning. In the end, trainees cannot refuse admissions. Please work with your attending if you feel a patient should not come to the ICU service. It's very, very hard for anyone to make a clinically accurate decision to refuse a patient from their bed at home. Inform the charge nurse of incoming MICU and step-down patients so that they can be ready and make a bed available for the patient. Every morning in the VA ICU, there's an ICU huddle at 8:30 a.m. This is a multidisciplinary huddle that allows you to make sure that your patients are going to get everything they need that day from our multidisciplinary professionals in the ICU. This huddle is attended by the charge nurse, the bedside nurses, the respiratory therapist, the speech therapist, the physical therapist, nutrition, and case management. On Thursday mornings when we have chest conference, you should prep the residents before you leave that they'll need to run this as we oftentimes are not back until more like 8:40 or 8:45. All other days should be led by the fellow. The key things to make sure that you've got organized for the day would be things like telling your charge nurse who's going to be transferred out, telling your respiratory therapist who you want to make sure is on a spontaneous breathing trial if it's not already automatically being done, talking to your speech therapist about doing a swallow evaluation to ensure a patient gets to a diet as quickly as they possibly can, making sure physical therapy is aware of a patient's need to begin therapy, making sure your tube feeds are correct, or for case management reasons, making sure that an LTAC is arranged or something like that. So this can be a very important huddle. We also do checklists in the ICU. These are meant to keep us all on track in providing quality care. These checklists help us to de-escalate antibiotics, remove lines and tubes that are unnecessary, and generally make sure the patient's receiving excellent quality care. These should be filled out daily. It's best if they're filled out by a resident or a student who's not presenting a patient. Oftentimes we all share the load in order to get these filled out. The person that's filling it out really needs to be able to speak up and say, hey, you forgot to talk about that Foley catheter, do we really need it? Rather than just checking boxes and filling it out. I wanted to also mention that we do have some things that, some tools in the VA that you may not be aware of that I wanted to put down on paper here. So we have esophageal balloon catheters. We have a hypothermia protocol. We have NICOM, 24/7 cath lab, a 24/7 IR lab, although neuro IR does go to Methodist. And just so you know, it's difficult to obtain an EEG after hours or on the weekend, so oftentimes we end up transferring these patients out. Of note, generally we take care of most everything that comes at us with the exception of we do not have ECMO, and oftentimes our high-risk bypass patients or high-risk CV surgery patients are transferred to nearby hospitals. As far as consent process, you use IMED consent to consent patients or family members. Only if the IMED system is down would you use paper consents, which are available in our team room. If you're doing a procedure that is emergent and the surrogate is either unavailable or there is no time to consent them in order to get the procedure done, then you can complete the procedure or the transfusion as appropriate and then complete the note and add me as a co-signer, Joseph P. Smith, and then talk to the family afterward to notify them that the procedure was completed. For non-emergent procedures with no available surrogate, when the patient is unable to consent, you need to call the ICU attending, who has to call the medical center director through the medicine service chief. As far as your notes, you need to write your procedure notes, especially your airway notes. The VA audits our airway management, so if there's no note, we get in trouble and we potentially lose our ability to intubate at the VA. Daily notes and H&Ps can be written by fellows. This should be done if the post-call resident is having trouble getting out on time. And as far as days off, residents that are off duty for a day off, the residents should cover each other for those days. But you should really help out when a resident's trying to get out on time and help them with either daily notes or H&Ps. The attendings will do the same. As far as airways, you must be an airway certified provider to intubate patients unsupervised at the VA. I've worked very hard to get it to the point that fellows can intubate and residents can intubate. Essentially, when you walk into the VA as a fellow, you are not to complete unsupervised intubations. You need to complete a TMS module and an exam. You need to do the mannequin sim lab airway management at Fairbanks. And then you'll need to obtain a letter from Gabe stating that you are proficient in intubation. Bring this letter to me or whoever the MICU director is at the time and get approval to intubate unsupervised from your current attending. So there's a lot of hoops to jump through. If you haven't gone through all these steps, then you either need to call your attending and have them come and supervise you, or allow anesthesia to do it. Anesthesia is the default airway provider at the VA. Of note, anesthesia will come to all code blues and will manage the airway while you're running the code. Also, residents can only intubate if they're supervised by attending. In other words, even if you're an approved airway certified provider, you cannot supervise another trainee to intubate. That can only happen when there's an attending present. As far as call, it's just like everywhere else on campus. You have a week on, week off, beginning Friday at 7 a.m. to the next Friday at 7 a.m. It's home call, but please come in to help the resident when needed. Residents rarely will ask for your help directly. You have to hear it in the tone of their voice and know their comfort level during the day in order to gauge when you need to come in. As far as when you hear about a consult on call, much of the time you can make recommendations over the phone and then see the patient first thing in the morning, but you absolutely need to come in for chest tubes, for things like a pneumothorax or an empyema, or a complicated parapneumonic effusion. But most others you would probably send to the ICU if you felt you needed to come in to see them. ICU moonlighters. We have ICU moonlighters that work a variable amount of shifts per month. It's either every third night or every fourth night, depending on how many residents we have. These are paid moonlighters. They're not all pulmonary and ICU fellows, but many are. The default should be that when a moonlighter is on, you should staff the patients by phone just like you would a resident. If it is a pulmonary and critical care fellow that's moonlighting, you may choose to allow the fellow to admit patients without staffing, but remember that you won't know anything the next morning when you walk in. So you won't know what came into your ICU and what to expect. The start time for the moonlighters is 6 p.m. on the weekdays and 3 p.m. on the weekends. I'll go ahead and put a plug in that we do hire mostly pulmonary and critical care fellows. And if you're interested in moonlighting, especially after your first year of fellowship, then reach out to me and I'll make sure that you get connected with the right people. If you're uncomfortable with a procedure or a patient, call me or call your attending. It doesn't matter which one from my standpoint. Call us day or night. And just know that not calling us is a much worse decision. Don't worry about waking us up. Make sure you're calling us when you need us. And there are some specific times when you want to call your attending. Those would be for an acute PE that you plan to TPA or send to IR, for pregnant females, which is rare at the VA, but it does happen, impending death, significant unexpected worsening of a patient, or significant change of care for a patient. Code blues are the responsibility of the resident to run, but you're the resident's example. If you hear a code blue and you're in-house, you should run, you should speak up, and if the resident isn't running the code, either help them get started or nudge them or take over. There's a protocol called the I'm Concerned protocol that grew out of concerns that nurses were not escalating their concerns to attendings, and it's simply to encourage communication. If a nurse feels like she's not being heard by the resident and or the fellow, they are asked to call the attending overnight rather than waiting until the morning after which the patient may have had harm come to them. So this is not meant to be rude to you. It's simply meant to be patient-focused and to ensure that we don't hear about things after the fact when we may have wanted to intervene overnight. Finally, there's a sepsis protocol. The sepsis protocol is a QSOFA-based ER triage protocol whereby patients with a known or suspected infection and a positive QSOFA are triaged to the ICU service. As you know, a positive QSOFA or a positive SOFA is associated with a high ICU mortality in sepsis, so therefore we want to get these patients to the ICU service. We are going to have these paged overhead as a sepsis response team to the ER. The ICU resident, because they're the 24/7 present provider in the ICU, is the person that will primarily respond to these calls. But if you're there during the day as the ICU fellow, you should go and help the resident. I realize that some of these patients are what I would call a false positive, meaning that they're not sick enough to go to the ICU. But please accept these patients unless your attending is involved in rejecting them. We are very actively collecting data and adjusting the protocol to make it work as well as possible. And finally, thank you for taking care of our veterans.